Okay, let's get started. First off, thank you both so much for being here. We really appreciate your help in this Women in IR series. I'm going to start off by introducing both of our presenters. Ladies first. So Dr. Pabon-Ramos is going to be speaking first. She is assistant professor as well as director of pediatric interventional radiology and co-director of the multidisciplinary vascular anomalies team at Duke University. She also has a master's in public health. Dr. Pabon-Ramos has served on the SIR Economics Committee in several facets. She has served as chair in addition to being the alternate CPT advisor for the Coding and Reimbursement Subcommittee and a member of the Coding and Nomenclature Subcommittee. Dr. Hawkins will be presenting second. He is an associate professor in addition to director of the Pediatric Interventional Radiology at Emory University School of Medicine. Dr. Hawkins' non-clinical interests include health policy, economics, and performance improvement. More specifically, healthcare challenges where these disciplines intersect. He currently serves on the ACR's Council Steering Committee as an associate editor for the JACR and chair of the Economics Committee for SIR. So thank you both for being here, and I'll let you take it over, Dr. Pabon-Ramos.
All right, thank you for the introduction. I'm going to start sharing my screen. And I'm going to begin the event with the first half of the lecture, which is the tree of vascular interventional radiology reimbursement. So I'm going to focus on the details, but it's a very important group of details that I'm going to be talking about. I have a couple of disclosures. And the objectives of my lecture is to describe how a CPT code is created. And the CPT code is the basics of reimbursement for any specialty and any subspecialty. So every healthcare provider should become intimately familiar with how a CPT code is created and how do you use it? How do you report it? A lot of practices in academia and private practice groups have coders. They either hire their own coders or they contract out the work of coding. But healthcare providers are the ones who report these codes, and they should be the ones to be familiar and audit the work that these coders are presenting, how they are coding your work. So a fact that some of you may not know is that CPT is a trademark of the American Medical Association. And there are two branches of the American Medical Association that are in charge of creating a CPT code. So the actual creation of what the CPT code describes, that the arm of the AMA that's in charge of that is the CPT. The arm that is in charge of valuation is the RUC. And I'm going to describe both arms of the AMA. So I'll start with CPT, or current procedural terminology. The CPT codes, as you know, describe medical, surgical, and diagnostic services. It is the coding system used to determine healthcare reimbursement in the United States. So who within the AMA is responsible for creating these CPT codes? It is the CPT committee, which has two main groups. The first one, which is kind of the steering committee, is the CPT Editorial Panel. And the CPT Editorial Panel is in charge of revising, updating, or modifying CPT codes. The CPT Editorial Panel has voting members, but very important, they're listed here, the voting members. At the bottom here is that there are two non-voting members, okay, that are CMS liaisons. So although the CMS representatives don't have voting rights in the CPT editorial panel, they are usually very vocal and do participate a lot in the creation of these CPT codes. And that's important to know. So who are the members of the CPT editorial panel? Here is the list of some of the current panel members, and I've marked in red 2 of the members because those 2 members are radiologists. Not only they're radiologists, they're interventional radiologists. And radiology is always well represented in the CPT editorial panel, which is very important. So the other group within the CPT committee is the CPT Advisory Committee. And the Advisory Committee is primarily composed of doctors nominated by specialty societies. However, keep in mind that to have doctors nominated into this committee, the specialty society needs to have enough members be members of both the AMA and the specialty society. So I don't know how many of you are AMA members, but when you become an AMA member, they ask you which specialty society do you think represents you the best? And that specialty society that you name is the one that's what goes into the count to determine if that specialty society has enough AMA members to have delegates in the House of Delegates in the AMA, which is what determines if those specialty societies can have members in other AMA committees. So when you become an AMA member or when you renew your AMA membership, pay special attention to what specialty society you designate as the one that represents you. So what are the responsibilities of the advisory committee? The advisory committee selects an advisor, an alternate advisor, and I mentioned physician in trainings. This is each specialty society has an advisor, alternate advisor, and physicians in training. By physicians in training, I don't mean medical students. Physicians in training are doctors who are training on how that committee works, because it takes years to train into how these committee works, how the work is done, so that eventually some of those doctors can become advisors or alternate advisors. The CPT Advisory Committee is chartered with creating codes, determining if codes are due to be deleted or if codes are due to be revised. So while the panel steers and decides, creates the outline of what needs to be done, the advisory committee is the one that does most of the work. The CPT Advisory Committee is also in charge of developing educational materials like the CPT Networks service, which is a service that the AMA provides where members can submit coding questions directly to the AMA, or publications that educate members on coding, like the CPT Assistant or clinical examples in radiology. And the advisory committee is also responsible of going back to their specialty societies and educating the members on correct coding practices. The CPT process is through different applications, and different applications exist for different types of code changes. The applications can be submitted by anyone, but most applications are submitted by either medical specialty societies or industry. The other way a request can go to the CPT panel to revise a code is through the RUC, which is the second arm of the AMA, the one that's in charge of valuation. If the RUC has a subcommittee that has these screens and they screen and detect certain codes that are not being used, maybe as they are supposed to be being used, and then they can either directly reassess the value of those codes, or if they think the descriptor of the code needs to be revised, they send the code back to CPT for the code to be revised. So that's another way the CPT can get a code revision request. So here's the list of the application process. And it happens in this order, but it's similar to a grant application where the CPT application is completed by the specialty societies. If they're the ones submitting the application, they submit it to the AMA staff. The AMA staff just make sure that everything, the application and the supporting documents are there. And then they assign that application to 3 members of the editorial panel. The 3 members of the editorial panel review the application, write feedback, and send it back to the applicants. The applicants revise the application based on that feedback from those 3 members and resubmit the revised application. And then they present that revised application in one of 3 CPT meetings that happen throughout the year. At the end, after the advisors or alternate advisors present the application in the meeting, the editorial panel takes a ballot action. So they vote on whether they're going to accept the application, they're going to refer it to a work group, they're going to postpone it to a future meeting if the application needs more work, or they're going to reject the application. Now, this is very important to understand, and it is that there are different types of CPT codes. I mentioned that there are different types of applications. That's because there are different types of CPT codes. They're listed here. The ones that we use most frequently are Category 1 and Category 3 codes. Category 1 codes are the established procedures. Category 3 codes are the new and emerging technologies. More and more interventional radiologists are using E&M codes because our clinics are growing. But when we are reporting the services that we're providing through procedures, it's mostly Category 1 and Category 3 codes. So how are Category 1 and Category 3 codes different? The Category 1 codes, which are the established procedures, those applications are a lot more involved. Those procedures, when you submit an application for a Category 1 code, those procedures have to be consistently performed, of widespread use. If there's a device involved to perform the procedure or the surgery, the device needs to be FDA approved for that indication. And there has to be a certain degree of literature support. So that application is submitted with all the supporting documentation. For Category 3 codes, which are the new and emerging technologies, there are nearly no requirements. It's just the application. Now, what happens after the applications are presented in front of the panel? Say the panel votes to approve the code, where if it's a Category 1 code, that code is going to go to the other arm of the AMA for valuation, to the RUC. Category 3 codes don't go to RUC for valuation. That's a huge difference. Why? That means that ultimately those Category 1 codes are going to have assigned RVUs, but the Category 3 codes, because they don't go through the valuation process, they don't go through the RUC, they do not have assigned RVUs. And what ends up happening sometimes is that insurance companies, and including CMS, don't cover a lot of those Category 3 codes because they claim that those procedures, those services are experimental. What has happened in radiology in the last 8 to 10 years is that there has been a big push both from AMA and CMS to bundle CPT codes. And what does that mean? Well, before bundling, there used to be component coding. Everything was component coding. And what that means is you perform a procedure and you report components, segments of that procedure with different codes. So you would report a procedure with multiple codes. But with bundling, multiple codes are grouped together into one code, or procedure components that are performed frequently together are bundled into a single code. So a procedure is reported with a single code or less codes than before with component coding. And there are pluses and minuses to both component coding, and bundled coding. So now I'm going to move on to the RUC, the other arm of the AMA, the one that's in charge of assessing valuation, and that's the Relative Value Scale Update Committee. As I mentioned earlier, the CPT codes that go to the RUC are the new or modified Category 1 codes approved by the CPT Editorial Panel, or those existing Category 1 codes that are detected by a RUC screen. And like I mentioned earlier, those codes detected by a screen can be referred by the RUC to CPT if the actual verbiage of the code needs to be modified, or they may remain in RUC just to undergo valuation. Now, notice that I highlighted modified in yellow, and that's an important point of the CPT and RUC process. Every time, since not only new codes go to RUC to be evaluated, also codes that are modified, edited, go back to RUC. When you talk to your specialty advisors or alternate advisors, sometimes they try to steer away from bringing a code to CPT for it to be edited. And this is the reason. Every time the code gets edited, it goes back to RUC for valuation or revaluation. And most of the time, that revaluation process results in a lower valuation or lower RVU value assigned to that code. So the advisors and alternate advisors try to steer away as much as possible from editing a Category 1 code. All right, so the Board of Trustees of the AMA charters the AMA RUC with assessing the resources required to provide physician services. Those physician services are described by the CPT codes, or recommending CPT code valuation, which are the RVUs, to CMS. And here I have highlighted the word recommend, because the valuation that the RUC assesses is not the value of that code automatically. It's just a recommendation that the RUC puts forth to CMS. The ultimate arbiter of code valuation is CMS. Similar to the CPT Editorial Panel, the AMA RUC panel is composed of multiple voting members listed here. And similar to the CPT Editorial Board panel, radiology is well represented, has always historically been well represented in the RUC panel. Currently, there is a panel member who is an ACR member, Dr. Donovan, and the RUC chairperson, Zeke Silva, is a radiologist as well. The RUC panel is divided into 3 subcommittees. The first subcommittee is a Relativity Assessment Work Group, or the RAW. That subcommittee is responsible for maintaining the new technology list of services to be re-reviewed with RUC as reporting and cost data become available. What does that mean? New technology. A new CPT code that was created because a new catheter device got created, came out into the market. Or a Category 1 code that used to be used for a certain procedure, but now it's being used for something different, which involves new technology. The RAW keeps track of that, and because it's new technology, there's not enough years of data to value that code appropriately. So they value it as well as they can with the data they have, and then they reassess. The other group of codes that the RAW is in charge of is a group of codes that is identified by the screening process. And some of the screens are listed here. For example, CPT codes that are reported in high volume, they're being reported a lot more in the last couple of years than they were before. The fastest growing based on CMS data services surveyed that initially were surveyed by one specialty and now are performed by a different specialty, codes, CPT codes that are reported together more than 75% of the time, or codes that when they were valued as being performed most frequently in the hospital setting, but now they're being performed more frequently in an office-based lab. All those are examples of screens, but there are there are more than 30 screening questions. So as a result of the raw screening process since 2006, since inception of the raw, about more than 2,600 codes have been reviewed again by the RUC. And I want you to take a look at this pie graph because it's very important and goes to what I spoke about earlier, where more than 1,000 codes here, right? 1,084 codes, 41%, the purple here. Those codes have decreased in value when they underwent the revaluation process. Almost 500 got deleted. A minority, 12%, 319 actually increased in value, and then 26% their value got reaffirmed. So most codes get either deleted or decrease in value. The second subcommittee of the RUC panel is the practice expense subcommittee. And that committee is chartered with reviewing practice expense inputs for new and revised codes and codes identified through the RAW or by CMS. And practice expense inputs include the cost of supplies, the cost of equipment, non-physician labor inputs. And that committee needs receipts a lot of the time, equipment receipts to appropriate value a procedure. And every little supply gets accounted for in this process. The number of tegaderms that you use, the number of cavi wipes that you use to clean the angio table. Every little thing gets accounted for through practice expense. The third subcommittee is the Healthcare Professionals Advisory Committee Review Board, and that one is mostly a group of limited licensed practitioners and allied healthcare professionals, non-physicians, that meet to develop relative value recommendations of codes that they report principally. There are 3 RUC members in that one, but by and large, it's non-RUC members who are healthcare providers, who are, say, physical therapists, occupational therapy, optometry, those allied healthcare practitioners. All right. So just like the CPT has the CPT Editorial Panel, which is the steering committee, and then there is the CPT Advisory Committee, which are the representatives of the specialty societies. The RUC has the panel, which is their steering committee, and also the advisory committee, which again are the advisor, alternate advisor, and those doctors that are training in how the RUC process works. And those are nominated by their specialty societies. Just like CPT, RUC holds 3 meetings per year. Unlike CPT, where the meetings are open, the RUC meetings are closed meetings. All right, so the RUC Advisory Committee is in charge of identifying codes that may undergo evaluation that affects their specialty. And if they decide that a code is very important to them, affects their specialty a lot, they are gonna survey data for that code. They're gonna survey their members to get data for that code. And they are in charge of acquiring the information, analyzing the information, and ultimately presenting that information in front of the RUC panel. So while the CPT process was an application in collecting supporting documentation, the RUC process is different. It's surveys, surveying membership. There is a centralized online survey process that's coordinated by the AMA, but the surveys are actually administered by the specialty societies. And the surveys are random. The societies randomly survey the members who are the experts at performing that procedure that's being described by the CPT code. And what are the questions that go into that survey that the members are asked to answer? It involves the time it takes that provider to perform the service, the intensity of the work, the physical demands on the provider, how risky is the procedure, physician liability, and then the providers are asked to compare that new code that is being surveyed to an existing or a reference, an index code that already exists. If multiple specialties perform that same service, then all of them can survey their membership and the data is pooled. And interventional radiology works closely with vascular surgery, sometimes cardiology, sometimes nephrology, depending on the code, to get surveys and pull the data and present that information to the RUC. So depending on how frequently a procedure is performed is the number of services, the minimum number of surveys that are required to be submitted by the specialty societies to support the valuation of that code. And the number of surveys are listed here at the top. So the procedures that are performed more frequently, more surveys need to be submitted. And you may think that obtaining 30 surveys, which is the minimum required for services performed less than 100,000 times per year, is not a lot, but sometimes it is very difficult to get 30 surveys. It is important to submit not just the minimum number of surveys, but the most surveys that the specialty society can collect, because the more surveys with similar results produce stronger data and there's a stronger statistical likelihood that that data is valid, which helps the advisors make a stronger argument in front of the RUC, and the RUC consider the data more accurate. Even with numerous survey responses and very robust data, not infrequently, once the results of the survey data is presented, the RUC panel ends up adopting the 25th percentile. So the service gets devalued some in that step. These are the steps of the RUC process. And it's similar to the CPT process, except that when the specialty societies submit the survey data, the RUC panel reviews the recommendations, but they don't get back to the specialty societies with recommendations on how to change things. They just review the results of the survey, and then the specialty societies, the advisors and alternate advisors present that data in front of the RUC panel. And there's a lot of back and forth, question answer, and ultimately the RUC panel takes a ballot action, a vote, and they either adopt the recommendation of the advisors or alternate advisors, they send the code for facilitation, they modify the recommendation, or they refer back to the specialty societies. But notice that unlike the CPT, where the CPT panel can outright reject and say, this is not going any further, in the RUC process, that is not an option. Something is going to happen with evaluation of that code. As I mentioned earlier, after a code goes through the RUC valuation process and the RUC comes up with RVU recommendations, those recommendations are submitted to CMS. And the CMS medical officers and contractor medical directors review the RUC recommendations and then decide what they're going to adopt, what value they're going to adopt for each particular code. They publish the proposed values in July in the proposed Medicare physician payment schedule. And then individual providers and specialty societies and industry can go back and comment on that proposed Medicare physician payment schedule. Ultimately, CMS reviews all those comments, and in November, they publish the final Medicare physician payment schedule. Very important, as I mentioned earlier, that CMS is the final arbiter of RVU values, and those values are published in that Medicare physician payment schedule. Historically, CMS had almost always accepted the RUC recommendations for valuation, but lately, CMS has devalued some of the RUC recommendations once they publish the final rule. And here we're getting to the end of the CPT RUC cycle. Takes about 2 years total. So right now, the codes that are going to be presented in the 2022 CPT meetings would go into effect in 2024. It takes that long for a code to be edited and approved in the CPT and then go to the RUC to get evaluated. Those are category 1 codes. The CPT panel actions are not final until the CPT book is published. And then code valuations are not final until the final rule, CMS's final rule for the Medicare physician fee schedule, is published in November. Updated CPT codes and relative values go into effect annually on January 1st. So in conclusion, if you're not an AMA member, become an AMA member. Specialty, when you're reaching the time to become an attending, make sure you select the specialty society that you feel represents you best, which in the case of this audience, I would hope would be the Society of Interventional Radiology. And if once you're an attending, you receive an email asking you to fill out a survey, please fill out the survey. It is very important to have enough surveys and enough data. And if once you're an attending, your group is asked to provide a receipt for an angio suite, a power injector, please submit that receipt so that a procedure that you perform can be correctly evaluated. Thank you very much. Please feel free to contact me directly with any questions or submit them to the Q&A at the end of the webinar.
All right. Thank you, Waly. Okay. Well, Waly gave you a lot of the essential details about CPT and RUC, and it is a very detailed process. And for those that are listening, don't worry if it sounds super confusing and complicated, because it is. And so for you all with where you're at in training, the objective of tonight is to really just kind of take away a couple of key over 30,000-foot themes, and then if you have some interest, know the place to go to kind of start digging in and getting into the details a little bit more. What I'm hoping to do here over the next couple minutes is just provide a little context on top of after CPT and RUC. What happens after we get a code and it goes and gets valued at the RUC? Where are all the other potential landmines for subsequent valuation and payment? So a very important concept for everyone here. Just because there is a code, and I'm going to show you why, does not mean you get paid for a procedure that you do. Okay. So let's go through this. Here are my disclosures. Let's just jump right in. So I'm going to talk about the physician payment embryology. So all of the components that go into actually having us get paid. And then at the very end, I'm going to just give you a little bit of update on things that happened for 2022 as it relates to the Medicare physician fee schedule. Important point, just to piggyback off of Waly, when we get a CPT code and goes to the RUC and it gets valued, okay, there are two valuations. Number one is for the physician work, and the RUC does that determination is good for all codes in all of medicine. The practice expense committee, the subcommittee that Waly referenced, determines the practice expense to perform procedures just in the office-based setting. Okay, so another important point. The mechanisms for valuing the cost, the practice expense of performing procedures in the inpatient setting, in the hospital outpatient setting, and ambulatory surgical centers is determined by a different mechanism. So very, very important concept. Beyond the details there, don't worry about for tonight. Okay, we talked about after it goes to the RUC. So now once it goes to the RUC, as Waly said, it then goes to CMS, and CMS determines if they like the value that the RUC has assigned it. Sometimes they do, sometimes they don't. They have been known to kind of give codes an extra 10 or 15% haircut if they don't like the final valuation. But then eventually a value gets accepted. And so CMS has said, here's a code. This is what we're willing to pay for it. This is the amount that we're going to pay for physician work. And this is the amount that we're willing to pay for the practice expense in the office-based setting. That value for the physician work and the practice expense in the office-based setting is published in what's called the Medicare Physician Fee Schedule Final Rule. Every July, CMS submits a proposed rule. The specialty societies look at what they like and don't like and do a whole lot of appeal processes and letter writings and coalition formings to try and appeal many of the reimbursement cuts. And then a final rule is usually issued around October or just into November. And so that is kind of that process. Now, so CMS has said this is what we're willing to pay for professional expense, and this is what we're willing to pay for practice expense in the office-based setting. And we'll get into why that may or may not actually get covered by Medicare contractors and private payers in a minute. Beyond coverage, there is even additional payment policies that can affect our codes, and we'll touch on that. And only after you get through all of this do we actually get paid for the services that we provide. So you kind of see all the different places where there are landmines for devaluation of our services. So we talked about CPT and RUC. RBRVS just stands for the Resource-Based Relative Value Scale. RUC stands for the RBRVS Update Committee. So that's the RUC, okay? So those two acronyms are semi-interchangeable. So let's get into coverage policy. So CMS has said, yep, we're going to pay for it. This is what the RVUs are for professional work. This is what the RVUs are for practice expense. And then what happens? So for Medicare, there are two types of coverage determinations. There are national coverage determinations and then what are called local coverage determinations, or LCDs. LCDs are much more common. And bottom line, there are 6 Medicare contractors across the United States. I'll show you a map in a minute. So another important concept, just because Medicare has said it will pay for this much for a certain procedure does not mean everybody everywhere in the United States will actually get paid for it. If 2 carriers have different local coverage determinations, may mean you can get paid for it in Seattle, but you won't get paid for it in Florida. Okay, another important concept. Then private payers, their coverage policies, the policies you can get, but how they determine their policies is completely proprietary. Okay, so if you really want to get into the weeds on why they have a certain policy, why Anthem doesn't want to pay for such and such procedure, why United won't pay for U fees, you can't really figure out why, even though you can't get your hands on the policy. This is different from Medicare and local coverage determinations. So all Medicare contractors actually have to have open meetings where people can attend and submit comments. So it is much more transparent than coverage policies for private payers. Here's a map of the Medicare contractors, okay? And so you can kind of see, depending on where you live, determines who your Medicare contractor is going to be. Again, there are 6 total Medicare contractors, each with a medical director. The information to contact them is actually very available if you ever did want to do that. So we have a lot of interventional radiologists very active at the local level with their Medicare contractor medical directors. So a different level of advocacy than what we typically think about. A lot of times we think about federal legislation and advocating for our profession on the Hill. This is a very different way that you can advocate for your profession. Again, coverage policy at the very basic level is, what diagnoses are we going to pay for particular procedures for? This uses a diagnostic radiology example, but obviously if you're getting a CT of the pelvis for appendicitis, that's going to get approved. But if your indication is headache, that's not going to get approved. This is a little more detail on Medicare contractors and local coverage determinations, which I kind of have already said. Bottom line, Each one's different. Each one has a medical director. Each one has open meetings, and you can have influence as an individual on development of their coverage policies, as opposed to private payers where we have no idea. We have absolutely no idea how they develop the coverage policies that they develop. And obviously, I think all of us are suspicious, and probably rightfully so, that many of the decisions are completely financially driven. Important concept on private payers. Some of them are literally franchised. So Blue Cross Blue Shield is a great example. I compare it to McDonald's. So yes, Blue Cross Blue Shield has a national data bank where you pull data from to make your coverage determinations, but no single Blue Cross Blue Shield is required to actually cover any particular procedure. So you might be in Alabama, Blue Cross Blue Shield, and have totally different coverage policy from what I have in Georgia, okay? Again, you start to see the heterogeneity and why healthcare economics gets so messy sometimes. 21st Century Cures Act was passed in 2016 with an attempt to try and improve the transparency with which private payers develop their coverage policies. They're supposed to provide a little bit, more literature requirements, greater transparency, open meetings, allow time for more public comments. But I'll be really honest, we're a little over 5 years into this, and I don't think we've seen much improvement. So private payers are still a bit of a mystery. So even after we get coverage policy, there's even additional payment policy on top of coverage policy. I'm just going to introduce this, just so you know. There's an entity called the National Correct Coding Initiative, which is a third-party company that the government contracts out with. Started in 1996, just to look at, bottom line, they look at a couple things. Number one, are there procedures that should only be reported a certain number of times a day? And what is that limit? And are there procedures that should never be reported together in the same day? And if they are, we should decline payment for those two, which is fine. However, there's not a lot of clinical background at the NCCI. And so many of their edits are they're just clinically erroneous. One example that stands out is they said that you could not do a liver biopsy and drain an abscess on the same patient the same day, which anybody with the brain knows you can do those two things on a patient, but that's an example of an edit that may actually impact us. So another layer of sort of bureaucracy after coverage policy determinations. These are the two types of edits I just described: incorrect code combinations and incorrect times of services reported in the same day. In the specialty societies, we have a very robust economics team that looks at these to make sure we don't miss inappropriate edits for our codes. And then after all that, you finally get paid. Okay. So the point I want y'all to take home is, just because you have a code doesn't mean you get paid. Just because CMS says that you can get paid for something doesn't mean your Medicare contractor, your local Medicare contractor, is actually going to pay for that. And proprietary, the private payers, their coverage policies are completely proprietary, can differ vastly, even between very close geographies. Okay. All right, let's talk about regulatory and legislative impact on IR, because there's even more places where we can take a hit than what I described here in the first couple slides. And this is an example of the 2022 Medicare Physician Fee Schedule. So the Medicare Physician Fee Schedule, again, a proposed rule usually comes out around July 4th. And we were looking at some really remarkable potential cuts, okay? And it's complicated. A lot of it doesn't have anything to do with CPT and RUC and the other valuation process. Bottom line is, we had a couple of old bills that were expiring. We had a pay-go sequester. Again, these are old legislation. This is going way back to Obamacare. We had, there's something called the conversion factor, which some of you may have heard of. The conversion factor is determined it's a legislative thing, and the conversion factor is a multiplier. So you take the conversion factor times RVUs, and that is the dollars that you're paid for a service. So we had a threat of a 3.85 reduction in our conversion factor, which that affects every single code that everybody does in medicine. So just a 3.85 just flat cut across healthcare reimbursement. There's another entity where we've been revaluing the supplies and equipment of office-based healthcare practice, and they did a redistribution. We were in the final year of that, so it's an additional 3% of cuts. Again, don't worry about the details. If you ever want to talk about this stuff, I'm happy to. I've been in the weeds deeper with this than I ever thought I would be in my life. But for the purpose of this audience, just know a number of regulatory places where we were going to get cut. Already on top of, in addition to dealing with RUC and raw screens and codes going back to get revalued at the AMA level. All in all, we were staring at about 14, almost 15% potential reimbursement cuts for IR, again, mostly in the office-based setting. The hospital outpatient setting and the inpatient setting did not get impacted the way that the office-based setting was. And I'll tell you, SIR did an outstanding job with its federal legislative advocacy team. We were able to end up limiting those cuts to only about 5% after we were able to reverse a lot of these things from the proposed rule. And when the final rule came out, in addition to some federal legislation that got passed, reimbursement cuts for 2022 are closer to around 5% rather than 15%. So I'd love to come and present to you about some great offense that we played, but in this case, it's good defense. And sometimes with healthcare policy and reimbursement, that's the best you can do. Now, I don't want to be too rosy about this though, because technical practice expense reimbursement in the office-based setting got crushed in 2022. Okay, again, this is just in the office. If you're doing it not in the hospital outpatient setting, within the office, I'm going to just show you a few codes. This is practice expense reimbursement, okay? This is not reimbursement for the professional work. But what's important, practice expense reimbursement is usually 2 to 3-fold higher than what we get paid as physicians, as human beings, for doing a procedure. So in the office, this is by far their largest opportunity for revenue. So these are a couple codes for kyphoplasty, vertebroplasty in the office-based setting. If you look in the non-facility column, the OBL, the percent change, you're just going to see a lot of red here as I go through a couple of these codes. So greater than 11%, 15% reduction in practice expense in the office-based setting for that. Vein, if anybody does vein work, this is, so vein centers looking at 12% and 14, almost 15% reductions in practice expense in the office-based setting. It's a couple dialysis codes, same thing, over 20% reduction for stent placement within a dialysis circuit in the office-based setting. This is the entire lower extremity PAD code set. So this was the biggest hit overall, but interventional radiologists, vascular surgeons, cardiologists, anybody who's doing these type of procedures, lower extremity revascularization procedures, you can see across the board, again, practice expense just decimated. Professional RVUs actually didn't get impacted hardly at all this year, which is different than prior years. And for a variety of reasons, practice expense really got hit hard as compared to professional RVUs. And if there are questions, I can go into more detail here shortly. Then just a couple of other procedures for those who do peritoneal dialysis catheters on your right, or there's a few people in the office dabbling with liver ablations. You can see a reduction of 11.7% for liver ablations. So in summary, revenue cycle is super complex. But I do think it's important, if you're going to be a practice leader in the 21st century, you got to have at least familiarity. You don't have to have in-depth, intricate knowledge, but you got to have a concept of how codes are created, how they're valued, and how we get paid. And if anything, also, hopefully that you learn that multi-tiered advocacy is really important for IR to be successful. We can't just be legislating on the Hill all the time. We need to be advocating at our local Medicare contractor level. We need to be advocating for our specialty at CPT and at RUC. We need to be advocating for our specialty with CMS and other regulatory agencies. Just one approach is not going to get it done. And we've gotten a lot better and do a pretty good job as a society in this respect. So that I will stop. I know we just have a couple minutes for questions, but happy to take any if there are some.
I think we have a question in the chat box from Ashwin, and it is, why does RUC devalue procedural codes more often than not?
I can take a crack at it, and Waly, you can hop in. So Waly talked about something called component coding. This is really important. So component coding, when the RVRVS did not go into effect until 1992, right? So it's only 30 years old, which is an important point. It's really young when you think about it. But when it came out in 1992, we were instructed as specialty societies to create as granular as possible as a code set as possible. So for an IR, you would report a code for getting access into an artery. You would report a code for catheterizing an artery, and then a different code for what's called radiology, RS&I, radiological supervision and interpretation. So every time we injected contrast, you would interpret that image and you would report an RS&I code. On and on and on. But we did exactly what we were supposed to do. But when we got into the era of bundling, any codes that reported together greater than 75% of the time hit a screen and then had to go back to the RUC for revaluation. Well, of course, we are interventional radiologists, so we reported imaging with our procedures 100% of the time. And so when Waly says we rewrote the entire code set from about 2012 on, it's not a lie. Every code for almost every single code for IR, maybe excluding tips and a couple of others that have survived the bundling barrage, have been revalued. And by being revalued, you saw in her graph the likelihood of any code being lowered in value. So it was more of how the original code set was constructed in 92, going through the bundling bonanza, if you will, of the 2010 to 2020. But Waly, I'm sure you have other context to add.
Yeah. I think that maybe they're referring to why the RUC passes the 25th more frequently than the median when the survey data is presented. And I don't have an answer for that. I don't know if Matt does. It's just how it's always been since I was involved.
I mean, almost always. If they pass anything higher than the 25th percentile, we feel like we've got a gift.
Right, right. It's a win.
There are a couple other questions in the chat box. The next one is, are there any geographical variations for reimbursement? For example, a procedure would cost much more if performed in a larger city where the cost to maintain the practice/facility would be much higher than a rural facility.
Yeah, on the there's a formula where the RVUs of a procedure get converted to what you're going to get reimbursed. And in that formula, besides the conversion factor, there's another factor called the gypsy factor, which is a geographical correction of how, the cost of living, where you practice, et cetera, that corrects for that geographic variation. Yes.
Great. Another question is from Lola, and it is, what is it about PAD interventions that led to the targeted reduction in technical reimbursement across multiple related interventions?
All right, Lola, I'm going to get into the weeds here pretty deep. But first of all, it's not specific. There's nothing about PAD that made the reduction. But what CMS proposed this year was to look at how much we pay our staff in the office-based setting. So our nurses, our MAs, people of that nature, because that had actually not been revised since 1999. Okay, so it had been 20 plus years since we actually looked at how much our staff salaries are built into the practice expense reimbursement for the procedures that we do. Now you might say that's good, right? Because obviously they've all gotten raises, their salary should be higher. Good, we're all going to get more practice expense. Unfortunately, it's a zero-sum budget or budget neutral process, what's called direct practice expense reimbursement in the office. And IR and vascular surgery and cardiology for that matter, we don't have staff-heavy offices. If you think about a family practice office, how many nurses they have, how many MAs they have, how many phlebotomists they have, et cetera, they have a lot more expense than what we do. And so while they had more money, again, zero sum, if they're going to get more money in that place, we have to pay for it from a different place. Top that off with, we have very few staff to pay. but our procedures are very expensive and only attributable to a single patient. So you use a super expensive stent, throw a Viabon or two in a lower extremity, that can only be attributed to a single patient. Compare that to like a CT scanner and MR scanner, where you can attribute the cost of that scanner to many patients over time. And what you end up with is the way that we paid for increasing the amount of money that staff across all of healthcare get paid is the very expensive single-use equipment procedures across all specialties, but especially IR, vascular surgery, and cardiology was the pay for. So way more than you wanted, but that's how we got there.
Awesome. Thank you, Dr. Hawkins. One last question from Lindsay is, what other important things does the AMA do? I really didn't know they had a significant purpose or there was any value in being a member.
Yeah, I think interspecialty, typically, I'm going to venture and say that, well, I'll speak for myself. When I was a trainee, I felt the same way. I had no idea what the AMA did for me. I had a better idea of, or for radiology, I had a better idea what SIR did for interventional radiologists and RSNA, the ACR did for radiology. And it wasn't until I became involved with CPT that I realized how important being an AMA member was, even if you're not involved in the AMA at all. But just being a member, paying that very expensive membership is important because, for example, the SIR, a couple of years, the SIR has been in a situation where it has barely fulfilled the minimum requirement of the number of members required to be able to have representatives in the House of Delegates and have representatives in the AMA committees, including CPT and RUC. And just imagine how disastrous it would be if the SIR didn't have an advisor and an alternate advisor in CPT and RUC. Forget about the panel, CPT panel and the RUC panel, just having an advisor and an alternate advisor. That would not be possible if there are not enough AMA members who select SIR as the specialty that best represents them. And yeah, I had no idea until I got involved in CPT.
Yeah, I would add just two other examples, Lindsay, because it is more than what you can comprehend when you're in training. I agree with you. The AMA probably doesn't have a whole lot of impact on your life and your being, if you will. But two examples: scope of practice. AMA is a huge advocate for physician scope of practice, and when you talk about different types of advanced practice providers kind of encroaching on physician practice, it's nice to have the AMA advocating for us. Certainly, there are some instances. I'm not suggesting we shouldn't be using APPs or working with them, but AMA is big on that. Number two, when all those cuts that I showed you, the possible 15% cuts, when we needed legislation to block some of those, we had the AMA in our corner. So the AMA led a coalition with like over 85 specialty societies. And the AMA is just so huge that when they really pushed that legislation, we were able to push through pretty significant legislation through Capitol Hill in short order to mitigate those cuts. So without something, an organization as big as the AMA, I don't think that would happen.
I think that's all of the questions. Thank you both so much for your time and for all of this knowledge. It's definitely a lot to take in. So we really appreciate you guys explaining, at least scratching the surface for us.
No, thank you.
Get involved early.
Okay.
Bye.
Well,
All
thank
right.
you all again. And thank you for everyone for attending. We appreciate it.
All right. Have a good night.